So I'm Scott Demarest. I'm a pediatric neurologist and epileptologist at Children's Hospital Colorado, and I focus on neurogenetic conditions for both my research and my clinical care. And the impetus for us having this conversation today is the support that we've been very lucky to receive from 4 different groups that have combined their efforts to help us get a clinic up and running here in Colorado. So that's Project 8P, supporting chromosome 8P disorders, Ring 14, SLC 6A1 Connect, and STXBP1 disorders. And so these 4 separate conditions all sort of fall within the umbrella of neurogenetic conditions and either developmental disorders or developmental and epilepsy disorders. And so have some overlaps, have some differences, but enough overlap that it made sense to kind of bring them all together in a clinic where we could provide a infrastructure that would help support the clinical needs for these 4 different groups. And I wanted to start with that partly as a thank you to all of these organizations for supporting us and helping us get this up and running, but also to let everybody know that there are 4 different disorders that we might be alluding to. And if I'm saying some alphabet soup that isn't your child's alphabet soup, you're not in the wrong place. You're still on the right flight here and headed to the right destination. So just as a heads up for everybody. We're excited to get this going. I'm going to pass it on also to the other providers here to be able to introduce themselves. And I wanted to also mention that we're lucky enough to have one of our other providers from the clinic who also joined us today, Dr. Courtney Santucci, who's one of our special care providers. And I'm going to ask her to introduce herself as well as we go through the introductions.
Shall I go now?
Yeah, why not?
Okay. Okay. Hi, everyone. I'm Courtney Santucci, one of the pediatricians at Children's Hospital Colorado. So my background is in care of children who have complex and chronic medical conditions of many types. And I work within a clinical program at Children's Colorado, which is called the Special Care Clinic. But from that background, I serve now on the neurogenetics program faculty for the multidisciplinary clinic that we're talking about today. And my role on that team is sort of the general pediatrician. And I bring focus on issues that, as a general pediatrician, sort of everything is potentially in my realm of interest, but particularly issues of nutrition and growth are what my portion of the multidisciplinary clinic days focus on. I'm glad to be here. Thank you for the invitation.
I'll take that as a cue to go. I'm Dr. Margarita Saenz. I'm a clinical geneticist, an associate professor at the University of Colorado Children's Hospital. I've been as a geneticist for about 14 years now and have taken care of many, many children with different chromosome rearrangements, as well as single gene disorders associated with epilepsies, brain malformations, etc. So I do what I love, and I love what I do, not just a cliche. And also as a geneticist, kind of the 4 big things that we look at and think about in clinics. What is your diagnosis? Making sure families understand what that is and going through a little bit of a biology lesson. Looking at treatments, what that means, what the direction is it supportive? How else can we improve quality of life with patients? Also looking at prognosis and recurrence risks for family. And on a personal note, I have a family member with a significant genetic disorder. So although I don't have the honor of being a mom or a dad to a special needs individual, I have the honor of being a little sister. Thank you.
And I want to say thank you I see Katie Angioni is on here, and she is our genetic counselor for our program as well. I won't make you switch your thing on and share, but unless you want to. But she has so much experience, and she adds so much expertise to her program with her genetic counseling. and just counseling patients and guiding us through as well. So I just am grateful she's on here. Lexa, why don't you go and I'll finish this up. But Lexa Mackey is on here, and she is our wonderful research coordinator.
Hi, everybody. I'm Lexa. I'm a research coordinator here at Children's Hospital. I've been in research for about 7 years now, and for the past 2 years, I've been at Children's Hospital, primarily working with Dr. Demarest, helping to facilitate research into neurogenetic conditions. So yeah, we'll go into the research relationship with clinic throughout the presentation, but I look forward to meeting and working with you all.
And I'm Tristan Dinkle. I am the nurse coordinator with the program. I have ran multidisciplinary clinics here at Children's Hospital for about 10 years now. I run a Rett syndrome clinic and CDKL5 clinic, which is just other rare neurogenetic disorders. And I've run a neurofibromatosis clinic before, and now I get to run the neurogenetic and the neurodegenerative disease programs here at Children's as well. So I'm just bringing all that wealth of experience as well into running this clinic as well, and get to work with all the families and coordinating care, fielding care, insurance, and you name it. And I'm running the clinic side of things and herding cats. I don't know, you name it. And that's what I get to do. But my favorite part is meeting all your kids and getting to talk with them and meet them in clinic. So
I think with that, it might be useful for us to run through a few of our slides. It's really only a handful of slides, but hopefully we can present some of the basic information about how this clinic is structured and what we're hoping to accomplish with this clinic. And then from there, we will have lots of time for questions and answers as well when we're done with that. So we already did a little bit of a welcome. We're recording right now for anyone who came on a little bit later. We can turn off the recording during the question and answer portion. Partly that's because we want to be respectful of everybody's privacy, and sometimes during question and answers, people start to make comments about their own specific child, and we don't necessarily want that to be part of the recording. We'll also preface this by saying our goal today is not necessarily to answer those specific clinical questions for individuals, given the setting that this is, but hopefully if we can get people to our clinic, we are happy to delve into that fully. So this is sort of how we were breaking this down. Welcome, we'll tell you who we are, how we structured the clinic, how research ties into this. We'll give you a little bit of closing thoughts and then have plenty of time for question and answer. All right, the next one. So you've met the four of us already. So I'm the co-medical director for this clinic along with Dr. Sines. Tristan is the main person who makes it all happen and work as the clinic coordinator. And then Lexa helps coordinate all of the research aspects to the clinic. This is our larger team of providers. You do not see every one of these individuals every time, but you see the vast majority. So maybe there's 3 providers here that are not automatically built into our clinic on that day. I'm not reading through every single one of these, but you can see that we have a whole variety of different specialties accounted for, with the goal of providing really comprehensive perspective on the challenges that your child might be dealing with.
Dr. Demarest, I would also echo and say that this format is built for family ease and comfort, in that, you know, we say it's a one-stop shop for us to provide for families, so you don't have to go to quite so many different appointments. But yeah, we'll lay out for you kind of what your clinic days will look like.
All right, Tristan, go for it.
What does clinic look like? That's a great question. That is what I'm there for. So we hold clinic the first Friday of each month, and that started this month. So I can tell you what it looks like starting this month. It went really well. We kind of changed our logistics just to really provide better care, and I felt like that really went well this month. What we do is we bring you in, and you'll see, and I'll kind of go through in the next slide, going through what that looks like in a second, just giving you a glance there. But we come in teams, and you stay in one place once you're into our multidisciplinary clinic. But first you'll go and make a stop in our special care clinic and see Dr. Santucci or her partner, Dr. Malik, and see the special care clinic in the morning. And then once you've seen them, you'll come up to the multidisciplinary clinic, and you'll stay in that room, and all the providers will rotate in and out of CU to see you that through the afternoon. I did put the time there, so it's not a surprise that it is a long chunk of time through the afternoon, because you are seeing quite a few providers, and we'll show those. As you saw on that slide, it was a good amount of people. But once you see kind of how that works in the next slide, you'll understand why. We also have the option that you could come in the day before and get some neuropsychological testing. What that looks like is, a lot of people are like, well, what is that? That's cognitive testing. That's looking at where is your kiddo at? What does that look like in terms of where are they at in terms of their learning? How are they cognitively functioning? How can we help them into school? And maybe the team can talk about that as well, but what does that look like? We also have a quality of care clinic, palliative care clinic, and what that looks like. And we can talk about what palliative care, everyone will talk about that here in a second as well. And that's the day before clinic. Insurance and Medicaid is billed for that appointment. I do pre-work on the front side to help you get that approved. And we do bill for that as a normal clinic appointment. If you're out of state, I get this a lot. Yes, please, let's try to get you in. Not all states are in contract with Children's Hospital Colorado, but I work very, very hard to try to get it approved and try to get you in. Out of country, I am currently working on one of the families of one of the disorders to try to get it worked out and figured out and see if it'll get all configured to come to clinic. Let's try. I know that a lot of families have asked what we can do right now. Telehealth for clinical care is not an option for us. I've gotten that email a lot. And at this time, for our clinical care, we cannot do that just because our medical licensing does not allow that. But to travel here to be seen in person, I am working on for out of country. It has happened for my other clinics, and I can try to make that happen for other things. So it's not out of the reason. I have had that asked, and I am working on that. And then, as we mentioned, the diagnoses that we are seeing in this clinic, it's a mix. I go on a first person basis, really by who contacts me first, but also whose insurance gets approved first. If my local patients are reaching out to me in Colorado that have insurance approved, I am going by those first, and then by the ones out of state that are also approved by their insurance. And it just fill them in. It's not any other priority by any means, by diagnosis or anything like that. It's literally insurance and what's easiest to get in and fill in, and then we go down the line. And also, anyone who's really ill and things like that, we will get in as well. We bring everyone back, usually on every 1 to 2 year time frame for follow-up once they've been seen. And then if people have needs that come up sooner than that, I will certainly work people in. If someone was reaching out and saying, I know we were seen this time and you said we couldn't come back for a year, reach out to me. We always make clinical care and needs and anything like that a priority and bring people back when they need to be seen. And it's just always a thing. Just reach out to me. I make things happen. It's never a cut and dry situation with us, but we will do what we need to do.
So I was going to just jump in here real quick, sorry.
Please
because
do.
I think some of these things are addressing a couple of the questions that have come up in the chat.
Oh, I haven't been watching, sorry.
That's okay, not a problem. So I would love it if we could do telehealth visits to anyone, not only anywhere in the country, but anywhere in the world. This is not just an issue of billing and funding. It's a licensing and liability issue for our hospital. This is not my choice. So we do have certain restrictions there. Essentially, we can't be providing medical advice to individuals in places where we don't have licensure and protections to be able to do that. So again, I know that with COVID right now, this is challenging, and asking people to travel here is not the easiest thing. I certainly hope, along with the whole rest of the world, that that becomes easier going forward. But I just want to sort of be honest, like this isn't our choice, but it is sort of the way it's set up. We are exploring the possibility of doing some like tele-research type visits and that sort of thing. But if we do that, then a tele-research visit is different than a telehealth visit in that we're collecting data, we're still not giving medical advice. So that doesn't really fix that problem of us being able to help support you and your family with what you're dealing with. So I just want to be really transparent about that aspect of it. We'll work with you to try to get you here, get things covered with insurance, do whatever we need to do, but we do have some limitations around what we can do within the broader system that we're dealing with in the US.
I have a quick question here in regards to the limitations. Is that because of the hospital, the state, the country, the insurance? Just so people kind of get a perspective, like maybe they might keep an eye on, like, well, when would we know when that might be allowed?
I think a lot of it has to do with medical licensure. For example, like for families who live in New Mexico, we don't have medical licensure to practice in New Mexico, and therefore we don't have contracts with that particular state. So then we can't provide care across that state line.
Okay, thank you. Yeah, that's helpful. I think maybe people understand that.
Yeah, the short answer was all of those things you mentioned play into this. It is a national, international, state, local issue. It really spans all of those in terms of the complicated system we have for healthcare in the US.
Referral, I don't need a referral to schedule you, but sometimes your insurance might need things in place. So what I usually have been responding back to families is giving you authorization paperwork in place and giving you the codes and the things to have your pediatrician or your neurologist go ahead and send all of the things into your insurance so that we can just lay that groundwork so that we're not fighting that battle when your appointment's scheduled and we're a week out and my insurance team's like, oh, hey, it's not approved. And then we're rushing to get everything approved. So I'm just go ahead and giving you those codes so that your pediatrician can just start the process ahead of the appointments. And so I don't need a referral, but sometimes your insurance needs to put some stuff in place. And some insurances, I know that, such as TRICARE always has to have, there's some things I know, some things I don't know. And so some things I can prepare for, some things I can't. Again, 10 years of experience gives me some knowledge. Insurances like to throw curveballs. So that's a halftime. All ages can be seen in clinic. We love all ages. The older, the funner for me. I love them all. But that's fun. Private pay is acceptable. I do everything I can to make sure you don't have to do that though. We will write letters to get you on Medicaid. I don't feel that any family should have to do that if possible, because it is quite pricey. I just don't want anyone to do that. If you're not on Medicaid, I really feel that we should get you on that and that you have every right to be. And we want to support you on that if you're in a state or in a country that you can be. Can I see patients from New York? It depends. I just for a patient for another clinic actually got a contract in place, but there's a few battles on that, but let's see. You just let me know. This sun's like creeping in on me. Do you guys see me like inching my way over here?
Not just about location. Theoretically, we can see anyone from anywhere in person in our clinic, depending on that individual's insurance and those types of things. It may be an easier lift or a harder lift in terms of just getting coverage for it. But there's no specific restrictions based on where somebody lives in terms of us being able to see them in person here in Colorado.
And this is a great question. Does senior team replace seeing the geneticist, neurologist, developmental? Dr. Science, would you like to?
Yeah, and I think that's a great question. And so we think of ourselves as the consultative service. So we're not trying to take patients away from their medical homes. Let's say you have a family traveling from Missouri coming to see us, and there's geneticists, neurologists, genetic counselors, primary care physicians. You have your home team who maybe are less familiar with these conditions that we're more familiar with. You come to Colorado, get your consultation. We give our advice and input and recommendations, and you still keep your home base. In instances for individuals who may not have a primary care team, we can help with that if you need referrals to somebody to call your home team. But that's a great question. There's a question about CHOP's epilepsy neurogenetic initiative, and I would say there is a lot of overlap with regard to the goals of each of those. So I have had other patients come from the CHOP program where they're looking to diagnose, give treatment, discuss prognosis, and give overall management care plans with a bridge to research. I would say that format is very similar to ours, where we have contacts as well and outreach with other scientists and individuals who are studying these conditions. If anybody has a more clarifying question on that, we'd be happy to answer that.
So I would just add to that there's 4 different disorders. Each of those disorders have a little bit of different activities that they have supported and are pursuing outside of Colorado. So that's both in terms of clinical care and research. For example, STXBP1 has been involved with CHOP and with Ingo Helbig there for a while now. We are communicating with Ingo. We're working with him in terms of like the research side of things. How do we do this together? I actually don't know for their clinic exactly what the scope of number of providers they see and what they provide in terms of clinical care, but we're happy to explore that and see how that aligns. And we are aligning for the research side of things, which we'll get more into as we move forward with this conversation. So we are trying to collaborate with all the relevant people in each of the 4 disorders, because each of the disorders are trying to move things forward in a little bit different ways. And we're happy to be collaborative with whoever is also trying to advance clinical care or research in these domains. So it may not be appropriate for everybody. If you have a great team and you're already doing a great job where you are, you don't have to come to our clinic. And we'll get into this a little bit more, but we're here as a service, not as a mandate to families, right? So we're gonna move forward with a little bit of some of this information, and then we'll circle back to some of the questions we don't have covered. Marga, if you want to go with this.
Definitely. So as we mentioned, talking about, well, what is your clinic experience going to look like? This is demonstrating to you the 3 pieces. So the first piece is going to be our children are having neuropsychological evaluations, which some of you may be familiar with, but this is an in-depth look to see children's strengths, weaknesses, how they learn, how we can support areas where they're more challenging. And then underneath that, you see quality of care clinic. We're going to take a little bit of time to talk about this one because it doesn't apply to all patients who come to clinic. Another name for the quality of care clinic is also called palliative care. And that's an important word for us to discuss because sometimes there are misnomers or misassociations with that word. So palliative care is not the same as something called hospice. Hospice we've heard of and think of as end of life comfort care. Palliative care does not fall into that. They do provide services for individuals with incredibly complex medical needs, but really I think it is appropriate to call it quality of care, quality of life clinic. So let's say you have a patient who has multiple organ system involvement, complex medical care, and we're trying to make decisions as to maybe an invasive procedure. That particular palliative care can help us weigh our pros and cons, our risk-benefit ratios, in making some of those decisions, but also think about it as quality of life. So that's going to happen as a first piece. And again, that may not apply to all patients. Next is your morning and special care clinic. I'm glad Dr. Santucci is with us. And Dr. Santucci, if you're comfortable, you might jump in and tell us maybe what the morning looks like a little bit.
For sure, yeah. Many children will benefit from additional nutritional support, and so that's one of the things that we can offer is there is a registered dietitian, so a nutritionist is part of my clinic and can see your child during that same appointment time if that's needed. Not all children need special nutritional help. Some are doing quite well with just a regular diet by mouth, but that is one of the parts that I take a look at. And any other physical kind of medical issues that stem from the diagnosis, but maybe aren't squarely in the realm of neurology care or rehab medicine care, I also tend to focus on. Sometimes this has to do with bowel and bladder habits or needs, or behavioral or sleep needs and interventions. And of course, there's overlap with Dr. Demarest in neurology, for example. And this is why during the course of the day, we discuss each patient's plan and try to make choices about, for example, if there are going to be medications used for sleep and the child also needs medications to control seizures, for example, we want to make a medicines plan that makes good sense from both of those perspectives. And that's pretty much it.
Perfect. Thank you so much for sharing that insight. And then the afternoon, like Tristan had put up from 12:30 to 4 o'clock in the afternoon. You see the list of specialists that you will be encountering. And as we mentioned earlier, we come in teams. For example, your neurologist, your geneticist, and your genetic counselor will all go in together. PT and rehab makes sense to have them go in together, and so on, as you can see. As far as titles, you may be familiar with most of them, but a family navigator is a unique role at our institution, such that it is an individual who very often is a parent or caregiver of an individual of a child with complex medical needs, who knows how to navigate the system in the community maybe a little bit better and different than we do. They have training and insight to support programs within the community, other tidbits and information on how do I apply for SSI, how do I get a shower chair or things like that. So that's what you can expect on a clinic day.
And I think a few of you have already asked, and I did put my email in the chat, but here's the information to contact me. You have all the ways to contact me: email, fax, courier, pigeon. I think we put the address even if you need to send a pigeon of some, or a bird of some source. But there's all the information, and you have the address now. You could physically come find us. To reach us. Email is there, which is probably the best. Phone is hard for me. I think email for me is keeping track of where we at in the process of having you come to clinic is always best for me, because I'm like, okay, I emailed them back. I asked them for insurance. Did they ever email me back? Nope. Okay, let me check on that. You know, I think that's how I do best with juggling everyone back and forth. But if you prefer to call me and just talk through the first time everything, I'm very happy with doing that. But then I do prefer some written form of something just to be able to know where we're at with things. And that works well for me. But, you know, once we're going through records and stuff like that, fax or email is great. I do ask that you always kind of send genetic testing results that first time. I do try to always touch base with the team and go, okay, is this patient the right kind of patient to be bringing in? Is there anything else we should be doing? Is this, you know, worth their time and effort? I always kind of double check things like that with our team as well. And just sending the insurance cards on the front side. I do have an insurance team. I am trying to get a better process on the front side. And one day there might be a good process in place that I can pre-check all the insurance. We're going to cross our fingers for that one. And birth date and everything, so I can get it in my thing in place. So and even if you just want to touch base and say, hey, you know, I don't know, anything, just questions, anything like that, please email. We're happy to help. Even if you don't think you can come to clinic, or if there's a point that you are having issues with your care and you really need your provider to reach out to our provider to talk, I want you to know that we do have a team here that can help. Even if you can't come to clinic, I'm gonna speak for Scott, but I want you to know that we have a team that can talk provider to provider to help guide care. Even if you are not able to come here for care, but if you get into a bind and there is some stuff that your team is needing guidance on, and they're like, well, is this related to our genetic disorder? And is there anything else that we could be doing? Or is there anything that has worked for this disorder that they know of, or anything, you know, anything like that? You're going down that road and you want to reach out to a specialist who knows more, that Dr. Sines or Dr. Demarest can help answer in regards to your genetic disorder. Your provider can call and reach out directly, and I can connect them. So know that that is a possibility, that if you're getting into some situations. I never want a family to feel alone just because they're not able to come to clinic. I think that's important to know that that we can offer to the community as well as specialists.
So that's one of the little bit of a workarounds. If your provider is asking us for advice, we can give your provider advice, and that's not giving clinical care advice to a family. And so we're always happy to try to just support general knowledge and care of these communities to the best of our ability. Most of the time, to be honest, local providers are doing a fantastic job, but sometimes they just want someone to bounce ideas off of, or to see, hey, have you ever seen something like this or dealt with this? And we're happy to do that. And that can be across international lines as well. So there was a specific question about this related to Europe, and we're happy to do that with any providers there. You can also put them in touch with Tristan via email, and she can kind of connect us all as well via email. Sometimes that's easier than trying to get us all on phone calls and things like that these days. But we can set up times to talk if necessary as well.
I wanted to throw in, I received a few questions that was early in the last day or so, but real quick, someone had asked, is there a certain age or stage where you think this would be most beneficial? And then someone had a similar question, is what age is a cutoff for care at your clinic? Thank you.
So there's no age cutoffs. We'll see patients of any age. That includes going into adulthood. We have a carve out for our hospital that essentially, if we're providing some care that's not reproducible in the adult world, we can see patients of any age. And there's not clinics for these specific disorders in the adult world. So we can do this for any age. I think it's hard to answer the question of when is it most helpful or valuable. I think if there's challenges in front of you, then we're happy to try to help, regardless of what age you're at.
I think also families should know that you get invited back to clinic just because you come for that initial consultation. If there are ongoing medical issues, we can see you back in a year, a couple of years. So, you know, we are all big believers of early intervention, but in the same breath, we've had adolescents, adults, people in their third, fourth decade of life who have had a new diagnosis and taken something away from our clinics.
We're going to move forward a little bit here to talk about how this connects with research. And I think this will also address some of the additional questions, and then anything that we've missed we'll get back to from the chat and any additional questions. So I wanted to address a couple of the issues around research in this clinic. First of all, why research? Well, these are rare disorders. We're still learning a lot about them as a community, as well as us as individual providers and as a clinic. We want to advance our care for all of these patients with these rare disorders and hopefully be able to move over time towards better treatments, better outcomes across all 4 of these disorders. What's that look like? Well, if we're going to do research on any individuals and be looking to combine that information and that data with other groups that are also doing research, then we really need a consent in place that lets you as a parent or guardian know, what are we going to do? How are we going to do it? Who will see this information? What information are we collecting? A lot more detail would be provided in an actual consent for anyone who comes to the clinic and will be offered to be consented. We sometimes consent ahead of the clinic remotely, and Lexa is able to do that. We sometimes consent the day of, and sometimes it happens after the fact. Honestly, it all depends a little bit on like how quickly you're getting in, how much advance notice did we have, what other things is Lexa juggling at that time, can influence a little bit of the timing around that, but we will be seeking to offer consent to everyone who comes to our clinic. What types of things are we looking at as part of the research? Really, this is looking at natural history data. What does natural history data mean? It means what kinds of issues, problems, or medical challenges does an individual with a particular disorder have, and how do those change or evolve over the course of their lifetime? So part of it is just saying what's going on now, but it's also looking at what was going on in the past and how does that change going forward. That's not so straightforward as it sounds. It's actually pretty complicated to collect that type of information and collect it in a pretty reliable way, meaning if I say so-and-so is having this challenge and someone else, do we know that they're actually both having it? Or are they having that a little bit differently? Does it look the same? There's a lot of nuance to all of that that we don't have to get into today, but that's the type of information we're trying to collect. As we move forward, I hope that we find ourselves in a place where there are more treatments specific to these disorders available. And then we'd want to start to think about what are outcomes looking like for those treatments as well. Most of these disorders are not at that point right now. And if we get to that point, it'll start to happen in the form of clinical trials primarily. But we will be interfacing with those clinical trials. We'll know about them if we're not offering them at our site. And so we'll keep people appraised of those types of evolution as well within any one disorder. We want you to be aware of a few things. So these 2 things connect together, may require some additional questionnaires, and there's a shared effort. So these are rare diseases. We don't lift mountains by ourselves for rare diseases. We are looking to do this collaboratively. We've already talked about CHOP. For SLC 6A1, there's a lot of work being done at UT Southwestern. So for all 4 disorders, there's a little bit of different research activity that's already ongoing. Some of the foundations, like AP, have their own registry that they're also trying to collect data in. We want to make it so that your time and efforts in filling out questionnaires, completing any data collection is put to the maximum use. We don't want you to have to redo things multiple times. One of the ways we're doing that is we are working with a group called RareX, which is a non-for-profit data platform system. And we're still putting in place some of the logistics around that and legal agreements and things like that. But the data that we collect from our clinic, should you consent, will ultimately flow to this group that will allow it to be combined with other data sets that each of the groups are pursuing in whatever direction they're pursuing, right? So the goal there is to put it there in RareX so that it can be shared. And we are not dependent on our site alone to be able to drive things for any advancements in this research. We're really approaching this very collaboratively. Because we want to combine that data, you may be asked to consent to multiple things. So you may have to consent with us, you may have to consent to RareX, and you may have to consent at another site that is also involved, or with the foundation that you work with for your disorder, like Project AP may have their own consent associated with this, for example. I want you to understand why you're being asked to consent multiple times. And it's because multiple people could end up seeing this data or sharing this data, and you need to have control over who you allow to see it and what happens with your data. So we can get into that in more detail and answer any questions you have in the consenting process around that, but I didn't want anybody to be surprised. Well, why am I asking consent again for this? It's to protect your rights is ultimately what it comes down to, but allow us to make maximum use of any data that you contribute. As part of that, while we are getting all of this infrastructure in place, we ask for a little bit of patience with us. We are trying to work on making it to where if you have contributed data in some other format that may be useful for us for clinical care in the clinic, that we'll be able to see that data without you having to fill out new surveys again, for example. We are working towards reducing duplicative work. Until we have all the right legal agreements in place and everyone has consented appropriately, we may not do that perfectly. So give us a little bit of grace as we're getting this up and running, but we respect your time, and we're trying to get that in place so that you can be efficient with your time as well. And again, the whole point there is shared effort. I want to try to be a little bit careful because different groups were sharing with different people, and what combined effort looks like is a little bit different with different groups. So that's why I'm speaking in generalities a little bit. But at the end of the day, we're not being possessive about any of this. It's not like, oh, we're not going to share. We want to control this data. We're trying to collect it to help move things forward for all of our groups. And it's really important for us to mention the last point on that prior slide. Participation in research is optional. You are not required to participate in research as part of coming to our clinic. You are welcome to, and there are advantages to the community of us being able to collect data, combine data, and learn more. But it will in no way change our care that we provide to your family, your child. We will be pursuing our best care for them no matter what, whether you choose to participate in research or not. And that ties into the next slide, which I want to be really specific about. So we sometimes confuse clinical care and research. This clinic is being set up to support clinical care, and we need to be very clear about that. We want to see families here so that we can support them in their care journey, supporting their local providers, helping to provide guidance and expertise as we increase our own expertise and see more and more of these patients with these disorders. We are pursuing research as a secondary aim for that, okay? So we've had some families who say, well, we're happy to come to your clinic if it supports research. And we appreciate that, and we want to pursue research. But we also want to be careful that the reason for coming to clinic and the reason that we have a clinic is to provide clinical care. And we want to make the most use of that as possible by collecting research information while we're doing that, okay? We don't want families to come to our clinic and say, well, you know, we came there and I didn't really get anything out of this. This was, you know, a waste of our time or something like that. We want to see you because you have clinical needs that we can try to help with. That's the primary reason for being seen in our clinic, because it is clinical care. And because I don't want there to be any surprises, that's also why our clinical care is billed for. Just like it would for any other clinic visit. Research visits you shouldn't have to pay for. And that's sort of a separate thing. These are not research visits. These are clinical care visits. We do bill insurance for them, which is why there's some barriers sometimes for people traveling from afar to get into our clinic and be seen. I just want to be completely transparent about that. Now, when you're coming here, we do structure our clinical care visits in a way that allow us to also collect research information for those families that choose to participate in research. I think that actually provides better clinical care also, because we do it through a structured process, which means we ask sort of a whole slew of questions every time. When you're asked to complete surveys and things like that, they may be for either purpose, okay? We, as much as possible, are trying to make them serve both goals, research and clinical care. You are not going to be asked, to complete any research questionnaires prior to being consented. Okay, so you have to agree to participate in research before we will send you research questionnaires. We will potentially send some clinic intake forms to you ahead of clinic. And that's really for us to understand what you're wanting out of clinic, what you're trying to get from us in preparation for seeing your child in clinic. That is true even for local patients who have all of their records in our system. Records can be thousands and thousands of pages long. And while we do review those records and look through them to try to pull out certain things that are important to us, we want to be aware of what your primary concerns are. And our intake form is our current best way of getting at that information. So we will be sending you questionnaires ahead of time, regardless of research or not. If you're doing research as well, we may send you a few extra things that are helping to inform us. Where we can, that's also going to inform on clinical care. This is also true for neuropsych testing. We do that because we think it's important for clinical care and it helps guide schools about what they should be doing with families. We also have that data available for those who consent to use it for research purposes. Okay, so really, again, this is a clinical care first clinic, but we also want to make use of your time and efforts to support research and help us all learn together. We apologize if any of it's duplicative up front. We're trying to minimize that as much as possible as we move forward. And I think with that, we are moving forward to question and answer time.
And just to kind of jump in here, probably have about 10 minutes, just to be, good with everybody's time and all of that for any questions that we have.
There's a number of questions about records. Where do we get them sent? How can we set up peer-to-peers for a particular disorder? Things like that. Your one-stop shop for contacting us is Tristan. So, whatever your question may be, we'd like to come see you in clinic. We're interested in research, but can't come to clinic. We want to do this, or we want to. How do we connect our local provider? Send an email to Tristan. That's the easiest thing to do. Explain what it is you're looking to achieve, and we will try to support you or tie you into the right people as best we can. Can you be too young to do neuropsychology testing? Yes, we don't do a whole lot of assessment on the child directly in a 3-month-old. So we'll meet you where you are as far as whatever the age of your child is. There may still be some questionnaires that ask a few things that give us some information about that, but yes.
I'd say from the toddler years though on up, it's possible to give objective data.
Yep. Where do they send the
she usually
referral?
does it when that ask questions and respond, like when she around 3 years, so like that she can go this color block and blah, blah, blah. And then they can respond back and she can gauge how they're changing over the years.
Kristen, maybe we could put the slide with our contact information and fax numbers, because it looked like the next question was, where do I send referrals?
Yeah.
There you go.